Okay. But I think we can get started now. Good morning, everyone. My name is Michelle McAllister, and I am here to welcome you to Optimum Life Reinsurance web presentation of the HIV updates to our underwriting manual. Today, you'll be hearing about the new information in our manual from 3 of Optimum's medical underwriting experts, Dave Barrett, Jim Braund, and Dr. Minas Joannides. Also, I wanted to let you know we have some upcoming webinars, one in May on the 9th. Monica Klink will be presenting on suicide claims. So let me tell you a little bit about our speakers. We have Dave Barrett, who has been at Optimum Re for 6 years. At the beginning of this year, Dave transitioned from his role as Chief Underwriter Associate to our new Vice President of Business Development and Underwriting Solutions. Dave has over 30 years of experience working in underwriting. He's been involved in all facets of underwriting, from creating accelerated underwriting systems, evaluating insurtech solutions, working with R&D on updating manual sections, and assessing highly substandard facultative risk for client companies. Dave lives in Columbus, Ohio, and outside of work, Dave's main focus is his 3-year-old grandson, Atticus, who he plans to develop into a soccer player in the English Premier League. We also have Jim Braund. He has been at Optimum Re for 18 years. He's a Chief Underwriter Associate in the Toronto office in Canada, where he also lives with his family. Like Dave, Jim has over 30 years of experience working in underwriting. He's worked for various direct underwriting, direct writers and reinsurers, both in Canada and the US. He's involved in fact underwriting, auditing, training, claims, escalations, as well as manual revision. And you will also hear some very important information from the Chief Medical Director at Optimum Re, our very own Dr. Minas Joannides. We'll be taking your questions throughout the presentation this morning. Please use the Q&A function in your Zoom to type in your questions for me. I will let the speakers know we have a question from the audience, and they will answer your questions. So that we have time to get through the entire presentation, we may not be able to address all of the questions, but our speakers will do their best. Those questions not answered during the webinar can be emailed to info.us@optimumre.com, or you may receive an email from us with the answers to the remaining questions. So let's get started this morning.
You're on mute, Doc.
Good morning, everybody. This is Minas Joannides, the Chief Medical Director at Optimum. Today, we're going to share with you our updated HIV positive section of the manual at Optimum Re. And then we have some cases and additional information for you as well. So I'm going to start it off. And just to add some excitement to the talk, I have some emergency construction going on in the house. So if there's water that starts pouring on me or some other emergency of that nature, you'll know what's going on. So let's get started. I hope the background noise isn't too distracting. Okay, you want to advance the slide, please? Michelle is going to be, she graciously agreed to advance the slides for us today. So the history of HIV positive underwriting at Optimum Life. I don't know that you are aware, but actually Optimum Re has been looking at applications of HIV positive applicants for the last 12 years. So we have substantial experience. And the applications that we looked at over the last 12 years, for those people that have been here that long, have recently been re-reviewed by us in light of the proposed update to the HIV positive section and new legislation that started in January 1 of 2023 in California. Next slide, please. So the California Insurance Code, as you may be aware, Code 799, says that in the state of California, you can no longer decline an applicant based solely on the results of a positive HIV test. And that if you were to take an adverse action or decline, it must be based on additional information that you develop on the case. So that came into effect on January 1st. And I'm sure that many of you have adopted new policies in reference to that. If you're not aware of this, hopefully this information today will be valuable to you. Next slide, please. So we did a thorough review of the cases that we've looked at in the past at Optimum on HIV positive applicants. And we recognize that improved antiretroviral treatment, or ART, for HIV disease has dramatically improved the mortality outlook for HIV positive disease, which now has really become a treatable chronic illness. So we reviewed the HIV positive ratings offered by client companies, and we've had discussion with those companies as well. We enlisted a consultant, Dr. Steve Rigatti, who's well known in the industry, and he reviewed current mortality literature on the HIV positive population, and he worked with us and recommended ratings that we have reviewed, and we have adopted those new ratings. So the HIV positive manual section was developed, reviewed, and approved by the Optimum R&D actuarial team, medical team, and the underwriting team. And so we're going to show you a little bit of what that looks like today. Next slide, please. So when you have access to our manual, this is the first page that you will actually see. There's some text for you to start out with. We talk about factors that you may encounter when looking at an applicant who has HIV positive disease and possible other problems that you may note, like recurrent sexually transmitted disease infections as well. Next slide, please. So the key three factors in our risk assessment are: when was the disease detected? And what is the current state of the immune system? In other words, what is the CD4 T cell count, which is key, as well as the viral load. So we're hoping that applicants have a very high CD4 T cell count and a viral load that's very low. And the nature of and adherence to the treatment using today's potent medications to treat HIV are key in treating these applicants. So we also want to have some kind of handle on the trend of how their disease has responded to the medication. And we'll talk about that a little more in a little bit. So in risk selection criteria, the HIV viral load hopefully has been fully suppressed for at least a year in order for us to consider them as an applicant. And as I mentioned, we hope that CD4 T cell count is at least 350 and higher is better, and that it hasn't fallen below 200 in the past. In order to help underwriters and medical directors evaluate cases, and especially if audits are necessary, next slide, please. We've also recommended the use of mini spreadsheets, which this is an example, with the date of testing that has gone on before, including what was the CD4 T cell count, what was the viral load, the page number of the APS, and what was the treatment at the time. And you can see this gives you a good trend, see how things have gone over time. Has the CD4 count remained stable and high? Has the viral load remained suppressed? And what medications have been used, since, as you're aware, people often are changed during the course of their treatment on different medicines. Next slide, please.
And Doc, just to say this, if you go back to that slide, we've been using this spreadsheet since 2012 when we first started insuring HIV positive applicants. And it's been really good as far as for specific cases, but it's also good to go back and we can see the trends from some of our clients.
Right, and as Dave pointed out, especially when we did this last review of all of our prior HIV positive cases, this was very helpful and key in looking at cases that had been underwritten in the past, and really gave us a nice handle on how the decision was made and what was used at that time. Thanks, Dave. Next slide, please. So the favorable characteristics or risk selection, the CD4 count greater than 350, an undetectable viral load, so under 200. And then, of course, we want to know what the follow-up is. Are they seeing an HIV specialist? Are they adhering to the outlined medication regimen? Is there an absence of other comorbid diseases, cancer, heart disease, or other things that may influence any action you might take? And what are the unfavorable characteristics? And that would be any AIDS-defining illnesses or other associated comorbid diseases or conditions like chronic hepatitis B or C that has not been cured or is not in remission, any history of lymphoma or leukemia, history of IV drug use, history of other substance abuse, or any ratable CAD cancer or vascular disease. Next slide, please. This is a list of the AIDS-defining illnesses, which are numerous, and you can see it's an expansive list, and if people have had these, it obviously signified that their immune system was depressed, and so these would be, we would regard these as a decline. Next slide, please. So you'll notice that the actual ratings have been blocked out, but what we wanted to demonstrate was that the sources of information that we want to use are the current age, the duration of complete viral suppression with CD4 counts above 350. And so not everyone who's attending today may have access to our manual, so we blocked out the ratings, but you can easily go to our manual if you have access and see what we came up with after much review and discussion about the ratings that we thought were best. Next slide. So the summary and recommendations. Our new HIV underwriting section has been developed to consider HIV positive disease as a chronic illness. All applications on HIV positive applicants will be reviewed by our underwriting team and the medical directors. We will treat all HIV positive cases with the utmost confidentiality and privacy, and we do not send unencrypted emails regarding cases identified as HIV positive. We also recommend that you do that as well, and that you, especially if you're dealing with vendors or agents or anything of that sort, you don't want people sending in emails where the subject line is HIV positive applicant or anything along those lines. Insurance companies are at risk due to the need for confidentiality about paramedics, administrative staff, agents, and all communications with applicants, insureds, et cetera. We assume the California auditors will be looking closely for any infractions regarding HIV positive applications after 1/1/2023. You probably do not want to keep lists and anything that they may feel is fair game for them. And if you have questions or any other situations come up regarding an HIV positive case, we're here to assist you. As I started the conversation, we have a long track record of dealing with applicants that are HIV positive, and maybe we can offer some particular assistance in that regard. So today we have the good fortune of having Dave Barrett and Jim Braund to go over some cases. And so we'll be moving on to that. I think, Dave, you are up next.
Yes, sir. Thank you, Dr. J. That was great. As you can probably tell in this slide, it's very difficult to read, but this is probably the best I could put together for one slide. But this is a good chart for an underwriter to become familiar with. It includes complete regimens such as Biktarvy and Cabenuva. So it's going to show all the treatments that are currently available, but the treatments are changing regularly. So we're going to post this on our website, and there's a link at the bottom. So, but it'll be on our website soon. Next slide.
Thanks, Dave. This is a chart showing treatment protocol. On the left side, or the left column, we kind of start off with the 0.0 in terms of HIV being positive, and the ART starts, and antiretroviral therapy. And it kind of shows you the protocol over time in terms of testing, CD4 testing, and HIV viral load testing. So as you move across the chart to the right side, there is increased stability, hopefully, with that testing. So in the first 2 years, it's every 3 months if the value is below 300. And then every 6 months if the value is CD4 is over 300. And after 2 years, we kind of hopefully reach a point of stability, and CD4 testing can be done every 12 months. So this is kind of a helpful chart in addition to our mini spreadsheet that Dr. J talked about. You can look at this as they start ART therapy. When is the testing for CD4 and viral load appropriate? Next slide.
Gentlemen, we have a question.
Yeah.
We have, well, actually, we have 2 questions. I'm sorry. First question is, confidentiality is important. If a client comes in for coverage where an exam, blood, urine is required, will we not have a responsibility to let the examiner know?
That is a good question.
That is a good question.
Yeah, for the most part, we assume the examiner is using the appropriate protocols when taking blood. So generally, it's not going to be an issue. If there is a potential finger stick, then they would just follow the protocols regarding that. So I don't think we've ever notified anybody in advance. Jim?
Well, we're a reinsurer, so we don't usually deal with those types of issues.
That's true.
It's really the direct writer that has to take care of those types of protocols, right?
Yeah, when I was, my 26 years in as a direct carrier, I don't think we ever notified anybody of that situation. So, and you had another question, Michelle?
Yes. The next question says, could you please explain what is acquired immunodeficiency syndrome or AIDS-related complex, ARC?
Doc, I think that's one for you.
Yeah, well, if people in the past have had one of those diseases that we listed, I don't know if you want to go back to the list, Michelle. It was the long list on the slide. There you go. Yeah, if they've had one of these diseases, like especially when HIV was, first known and people were not being effectively treated because there really wasn't any good treatment to use. People could get one or more of these particular diseases, and so their immune system was just not able to handle anything along these lines. So they had very low CD4 counts and were at risk of all kinds of things. So pneumocystis pneumonia was common. Many people had Kaposi's sarcoma with dark purple patches on their skin, and all kinds of other issues along those lines. So that defined AIDS, and people still, people in the lay public especially still confuse AIDS and HIV positive, which, as we know now, because of the good treatments, are distinctly different diseases. So what we're talking about today is HIV positive disease that we consider a chronic illness that's being treated effectively versus anyone who has these AIDS defining illnesses. We really don't use the term ARC anymore. That's kind of old school, you might say. So I would stick to just HIV positive disease and AIDS defining illnesses. Does that answer the question?
Okay. There's a second part to that question. It says, if diagnosed with the above, how would you assess the mortality?
For AIDS defining illness, yeah, we're not accepting anyone that has an AIDS defining illness currently, so they would be declined. If they've had it in the very distant past, obviously we would want to know all the details. Let's say they had something in the very distant past, but they're now being effectively treated and everything is going well with great CD4 counts and suppressed viral loads, then we would consider that in a more favorable light.
Okay. And one last question. What specific factors contributed to ages less than 30 being declined or postponed until age 30? I'll read it.
Sure.
Do you need me to read it again?
No, but why don't you go to our slide that has the ratings with the blue box?
This one?
Yeah, we don't have our ratings here, but you can assume that the ratings less than 30 are not going to be as good as the ratings above 30. And we just use that in reference to the mortality data that Dr. Rigotti looked at and discussions with other companies that we work with. So as I said, you can go to our manual and take a look and see what those ratings exactly are. But younger people that are still kind of finding their way and may not be in a stable situation are more highly at risk. So that's why we use differential ages as part of our rating scheme here.
Okay. One more question just popped up. I see text in your manual regarding the spreadsheet, but there does not appear to be a link to the spreadsheet. Where is the spreadsheet located?
It's in the forms section. So if you go to the forms, it's in there.
Okay.
Yeah.
And
There's a PDF of it, so you can utilize that.
So there's a separate forms location within the manual.
Right.
Can you see me, Dave, at all?
I can.
Oh, perfect. Just wondering, I can't see myself.
can't see myself either.
Okay.
Okay, so we go to slide number 14, all right? And if you have any other questions, feel free to just let us know as we go through. Very informal. So what to watch out for? This is that's one creepy eye. I didn't put that on there, but it's there, so we're gonna have to deal with it. There's very poor mortality for people under age 30 as far as HIV positivity. We want to make sure CD4 counts are over 300. They're best if it's over 1,000, and then no sustained CD4 counts less than 200. There are some times where they've been under 200, like a remote time of like 10 years ago. We would consider that to be negligible at that point. We also want to make sure the viral load is undetectable. Make sure there's adherence in the duration of the antiretroviral therapy, minimum of 1 year of compliance and control. So other things not contracted due to IV drug use, that's a significant mortality factor. No major mental health issues, few STDs that are, not chronic or persistent. So, we're looking for people that are, even though this is a chronic condition, it's a condition that has a lot of comorbidities. And if those comorbidities are present, we want to make sure we're, looking at the case in a holistic point of view. So we want to be conservative on these risks. We've been conservative on these risks since 2012 when Optimum first started insuring HIV positive individuals. And to be quite honest, the data that we ran in 2012 where we got the ratings is very similar to what we're seeing now. So that's shows a testament to how well we did originally when we priced the risk. We also want to make sure there's no hepatitis B or C, or unless it's been cured, especially with Hep C. No cardiovascular disease or significant risk factors. So obviously no history of any age-defining illness that Doc talked about earlier. And if you come across cases and you don't feel like they're the best of the best or they're very good, feel free to reach out to us. You can talk to us via phone, via email. It's probably better via phone, but you can also send us your facultative cases. So
Okay, Dave,
Next
we have
slide.
a clarification question. Is it age over or under 30? Slide says over 30, but stated under 30.
Yeah, for this slide, we're saying, the age diagnosed over 30 is a better risk factor than somebody diagnosed under age 30. So, these are kind of the favorables that we're looking for, but I also interjected some of the concerns as well. So
Okay.
this
Okay.
this is your positive client that comes in for HIV coverage or for insurance coverage, and they have they're HIV positive. So next slide.
Okay. Well, one more question. Sorry.
Yep.
We have well-controlled HIV, no cardiac artery disease risk factors except smoker. What is the reason Optimum Re is adding additional plus 50 for smokers? And there's a second part to that question.
Yeah, as far as, and Doc, you can talk to this too, but from what I saw, the mortality that the data shows, there's an actual added risk for somebody who's a tobacco user, correct?
Yeah, it's very perceptive, whoever picked that up, because I wasn't on the slide that long, so get a gold star. Actually, smoker, in the general public, about half of HIV positive people are smokers. However, in the insurance population, it's probably going to be much less likely that HIV positive applicants are also smoking cigarettes. But if they are, the risk is actually more than the additive of just a regular smoker rating and the HIV positive rating. There's actually evidence to show, and mortality backs it up, that there is an added mortality risk in addition to just the usual smoker rating. So that's why we did that.
Okay, and the second part of that question says, what if the client is smoking marijuana, minimum due to moderate use? Does this require an additional rating?
Yeah.
We would not look at that as an additional rating. I mean, Doc, you're about to say it too.
Yeah, what we're looking at, the risk with smoking tobacco is, obviously they're going to be a lot more exposure to carcinogens and toxicity to the respiratory tract. Whereas, we regard using marijuana more as a recreational event that's not going to be, as chronic as smoking tobacco products. So we don't rate marijuana use in that regard.
The only thing I could see, Doc, is if they're using moderate to more than moderate use of marijuana, maybe they have some sort of illness that's not been detected, but I would say that's probably not.
Yeah, if the
huge
use
factor.
was actually, you know, disturbing their respiratory system, or they had, you know, other symptoms in regard to, let's say they had asthma and they're smoking marijuana and the marijuana is irritating their asthma or something like that. Yeah, that would be obviously an increased risk. But in the typical client that we're going to run into, it's probably not the case. But as you say, Dave, it could happen.
Okay, next slide, please.
Thanks, Dave. You've stolen a bit of my thunder here because
Sorry,
I'm talking
buddy.
about unfavorable characteristics now.
That's okay.
So we'll start off. I mean, we're looking at basically the population. There's a higher incidence of prior IV drug use. There's some risky behavior often going on. There's more alcohol abuse. As Dr. J said, 50% of the people have smoking history or are currently smoking, I should say. So that's kind of a catalyst for CAD cancer risks. And these people are at risk for those types of things on an accelerated basis. Also, there is higher incidence of Hep B and C. So we have to be kind of cognizant of kind of the background, and you'll see that often in the APS. They'll have this type of risky background already. So we have to judge how we're going to take that into consideration. And as I said, HIV positive is kind of, and the treatment is kind of an accelerator or a catalyst for CAD cancer risks, neurological disorders, even renal insufficiency. So people will not necessarily die of AIDS, but they'll die a little bit prematurely of these other kind of diseases of older age, but they're just somewhat accelerated. And that's it. Next slide.
Sorry, I was muted. So let's go back to that prior one. Just had some notes here. So let's underwrite. The following cases are what we've seen over the past decade. The names have been changed. Feel free to ask questions as you've done so far. And you know, we're going to try to address any concerns going forward. So it's a free-flowing discussion. And but again, we won't discuss specific ratings. Let's go to the next slide, please, Michelle. Okay, so our first case, Mary Ann, she's a 44-year-old female. She was diagnosed with HIV at age 32. You can see the meds that she's on. She's had good adherence to treatment and follow-up, but she did have a few episodes of missed doses years ago. She's currently has controlled asthma. However, she does run marathons. She had herpes simplex virus a few years ago in her eye. That's been taken care of. There's no active meds or infection, just some residual scarring. So concerns, acceptable. I guess I didn't read the viral load. The viral load is undetectable since at least 2009. So that's about 13 years. Her CD4 ranges go from 529 up to 999. So any concerns on this? I guess I'll wait just a second.
I have one acceptable.
One acceptable, yes. So. Yeah, the only concerns on this, we really want you to watch out for skipped doses, since it doesn't take much for the HIV virus to mutate and cause resistance to prior working medications. So we're gonna see, it's kind of like some of the other slides I'm gonna probably talk about. A doctor may try different treatment regimens to see what is going to knock down that viral load and, you know, show good results as far as their HIV protocol. So next slide.
I think there was a note in one of these slides regarding, it's like similar to psych meds where people kind of cycle through psych meds to find the appropriate one that causes a correction. So similar with HIV. This
I have
next, oh,
another question. I'm sorry, it just popped up.
sure.
Says if the client is declared to using pre-exposure prophylaxis, but no HIV or HIV negative, please discuss about long-term use of antiviral treatment. Please discuss about long-time use of antiviral treatment would require rating.
Sure, I'll be happy to take that one. So if we're talking about PrEP, in other words, preventative. So in the past, many people used Truvada and some people still do, but Descovy is the new version of that drug. That's a completely different subject, and actually, hopefully no one is rating someone who's using PrEP for using PrEP. There may be other reasons to rate that case, but we would not be rating anyone who's just using PrEP with effective medication like Descovy or Truvada. So that's someone who's trying to prevent the disease. There were issues with bone and renal problems with Truvada. Gilead, who makes both drugs, both Truvada and Descovy, is being sued in a class action suit for keeping Truvada on the market when Descovy was available and did not have the bone and renal problems. But we don't really, unless somebody has information in their APS about, renal or bone problems, we wouldn't necessarily just rate someone who's on PrEP for the potential of future bone or renal problems. So one of the reasons we kept that as a different section is the section that we have in our manual specifically just for HIV positive disease, and we wanted to keep it, just in that realm. So I hope I answered that question.
I have no more questions.
Okay.
Next case is David. David is a male, 38, diagnosed with HIV at age 31. He's on Atripla, which is an HIV ART, Med, and Lipitor. He has a prior history of syphilis and schistosomiasis, dermatitis, which is a freshwater parasite. It's usually acquired in Asia or Africa. He's fluctuating kidney function tests, but his GFR is within normal limits. And we figured that the KFTs were likely a result of the HIV medication he was taking. He was compliant with meds and treatment, and his viral load was undetectable, which is great. He had a CD4 ranges, as you can see, 512 to 795, which was also very favorable. So as we were going through this case, one of the issues, I think, was, you're going through an APS and you find something like syphilis or schistosomiasis or some of these kind of concerning infections. You're really looking for resolution of those things later on in the APS. So if you don't find that, you're always concerned that have they actually cleared these types of infections? And if we put that together with HIV positive, it's problematic. So if they cleared these other types of infections, we're probably going to make the rated offer and apply the manual rating. If they haven't and you can't find it in the APS, that's a concern, and we probably postpone those.
Yeah, especially if they have chronic persistent syphilis, or it's going to be problematic. So
right, yeah, we're looking for the resolution of those other infections.
Yeah.
Right. One of the things we noted when we did our review in preparation for this update was several of the cases, people had had syphilis in the past, and they still had a small residual titer when they had an RPR test done for syphilis. So if they have a 1 to 8 titer, that may be evidence of prior infection that was effectively treated. if somebody did not have a history of syphilis and you see a 1 to 8 in an APS or anything higher than a 1 to 8, that may be evidence of a new infection with syphilis. And so that may warrant penicillin treatment to take care of that. So you just have to be cautious about when you see the titers of an RPR from past or something that's current.
Okay, and I have a attendee answer of approved. So will you address that?
Yes.
Yeah.
There we
Okay.
go.
Next slide.
Is there another question, Michelle?
There is, I didn't know, would you guys like to come back to this question?
No, we can talk
No,
about
go
it right
ahead.
We
now.
can talk about it now. Okay.
Yep.
Yeah.
So the question I have here is a PrEP drug use with evidence of risky behavior or lifestyle, for example, multiple partners, non-compliant with prophylactics, etc. Is that acceptable? And or what is the rating?
Yeah, it's very I can't say it's borderline anymore, but it used to be, as a more junior underwriter, 10 years ago, we would take more of that into account. It's kind of a moral or ethical type of situation, and so it's not a concern, but it's not something we would kind of hold our hat on and make that kind of judgment. Hopefully I'm not spinning a web. Doc, you want to talk anything about this, or Jim?
Yeah.
Well, we want to avoid making
Yeah.
kind of lifestyle judgments on our applicants. We want to look for concrete evidence, things that we can kind of act upon. And as we said, syphilis, if it's not cleared, that would be problematic. Human papilloma virus, this is another kind of issue in the background that is kind of a problematic for different types of cancers. So those issues. Dr. J, do you want to?
Yeah, I would, I think we've all kind of learned over the years how to approach this. And I think my approach has changed dramatically. And I would not make any adverse comments about anybody's lifestyle per se. I would, as Jim said and Dave said, I would only use objective disease processes that are ongoing with the client when they apply. And I would avoid all comments about, whether or not they're using protection or things along those lines. If they have documented evidence of disease, which you feel is a risk factor, you can use that. But I would try to stay away from, in your notes that may be, used at some point in the future. I would avoid all comments about lifestyle or anything along that line. And I think that'll serve you well in your underwriting, any underwriting situations.
Yeah, you both said it better than I could. So it's I think you stick to the facts. Usually if there's things that you talked about, there's usually other factors that you kind of spotlight. If they're having a recurrent STDs, or there's other, like HPV with it's usually something else there that's going to be a major risk factor that you want to kind of hold on to. So
Okay.
next slide.
Yeah.
Oh, go ahead, Michelle.
I'm sorry, you can let me know. We have 2 more questions. One was on the prior slide for the Marianne case.
Yep.
This attendee said we could do it at the end of our, do you guys want to address it now? Actually, we have 3 questions now. So
We can address it now if there's specific question.
Yeah,
And
go
as
back
far
to
as-
Marianne.
all right, let me go back to Marianne. And the question is, can you give me your question on Marianne? The attendee. I'll move on to another question and we'll come back to what
Yeah.
she gives me the question on Marianne. The next question says, a file with a past syphilis history, if APS does not indicate no recent testing, would you ask for current STTs, including syphilis?
Yeah, I think that should be well followed in the medical record documentation, but if it's not, then I don't think it's wrong to ask for those specific tests, Doc.
Yeah, like I said, it's the RPR titers are kind of tricky. You have to know what you're doing. We're here to help if you have any questions. So hopefully they have those titers. And in a lot of the cases that we reviewed, again, even cases from the past, they did have that kind of information. So hopefully, if you have a expert HIV doctor taking care of the client, they're going to include things like that to make sure that they're up to date on exactly what's going on. And if somebody was exposed to syphilis in the past, you want to make sure they were effectively treated with the appropriate penicillin, or if they're allergic to penicillin, whatever else they could possibly use. So it is something that takes a little expertise, but always good to have as much information as you can use if it's available.
Okay. And for the question on Mary, says, I noticed she was using several asthma meds. Can this be affiliated with her having HIV? Doesn't HIV increase the risk for pneumonia?
Well, as I said, in the distant past, when we didn't have effective ART treatment, there were all kinds of bad pneumonias that people would get. In this case, this is just kind of an independent illness that this person probably has. So, hopefully the asthma is being treated effectively with the Pulmicort and Flovent and Xenopex. So it doesn't necessarily mean that the asthma is due to HIV. But as I said, if say this person was also a smoker, obviously that would cause you to be worried about their asthma plus smoking plus HIV. So
it's an interesting case because she runs marathons, Doc. So I mean, this
right,
is
yeah,
a real case. So
yeah, maybe she has exercise induced asthma or something like that.
Right.
That may where she has to take these medications before she competes or whatever, that kind of thing. So I'm glad people are bringing up pulmonary questions, one of my favorite areas. So feel free.
We have one more question. Do you guys want to take this now or to the next case?
Take it now.
Go ahead.
Okay. What is the clinical definition of cured with regards to HIV?
Yeah, well, very few people are actually considered cured. There are rare instances that we're hearing about where people, don't have any evidence anymore of the disease. But what we're treating it as basically, and that's what this whole talk is about, is we're considering it as a chronic illness that where we can consider them for insurance, when they're well followed and all their factors are favorable. So it's kind of moved from a deadly, death sentence kind of disease to a chronic illness which can be effectively treated. So that's why California spent many years, studying this and wanted the best for the people that lived in their state. And that's why they actually passed regulations to allow people that deserve life insurance to be able to apply for it and not be judged too harshly if it was not, and it wasn't based on the facts. So that's why we're, dealing with this today.
I think we're on to Franklin, right?
Yeah, Franklin.
Yeah.
We do have one more question. I don't know if you guys want to proceed or.
Yeah, go ahead.
Go ahead.
Okay. So if the insured is with good follow-up and compliance, standard would still be the best rate.
Well, we're not discussing ratings, but let's just say we're heading in the right direction with treatment. And so we're hoping that people fare well, if they have a high CD4 count and their virus is suppressed and they're on the right medicines and they don't have any other diseases, we can hopefully offer them a policy with a rating. And that's probably as far as I can go because we don't want to get into any, antitrust issues.
Yeah, mildly substandards. Good enough, right, Doc?
as we said, you know, the CAD and cancer risks and other risks are basically accelerated. So they die, maybe not of AIDS, but accelerated diseases of older age. So there generally is extra mortality, right?
Yeah, what I would recommend is if you have access to our manual, please, check it out. And you can be sure that we have discussed this far and wide with many companies, and our ratings are not dissimilar from, the vast majority of clients that we have talked with. So, I think people recognize from the mortality data that's available what the approximate mortality is. But we are heading in the right direction, and maybe someday, they will be equal to a standard risk at some point in the future, hopefully.
And it's interesting because being in the industry for 30 plus years, it used to be you rated somebody with depression or anxiety was pretty much always rated. Then, then a lot of companies started going down to where it was a standard risk, and some are now into preferred. And I've seen that a lot of different conditions. So, if we're treating this as a chronic condition, and the medications are getting better and the protocols are getting better, that's not far off in the future, I don't think. Let's talk about Franklin. Okay, thanks. So Franklin diagnosed at age 35, at current age 47, overall is compliant with his medication and treatment protocol. CD4s ranging from 436 to 1067. Latest counts are in the 700, so it's kind of up and down a little bit. Viral loads undetectable since at least 2010, so that's a solid 12, 13 years. Meds are atriptyla, gabapentin, Norco, and cyclobenzaprine. Episodes of genital herpes, but resolved quickly with Valtrex. Has some depression, no meds, but it's talked about possibly going to the doctor, some back pain, and occasionally smokes marijuana. Concerns, is it acceptable? I mean, it's a pretty solid risk. He's doing well as far as follow-up. The treating physician says he's been maintaining excellent immunological and virological control. So it's not, it doesn't seem like a huge risk for us. So I would say this is okay to offer on. Next slide, please, unless there's questions. Okay.
Grant. Okay. This client had HIV diagnosed at age 24, current age is 42. He had a positive viral load at some time in the past, but has been undetectable before that point and since that point. His CD4 values are good. As you can see, 515 and 810 range. Meds, Truvada, which is really a PrEP med. Propanol, Valtrex, I think that's for usually herpes. Clonopine, if I'm pronouncing that correctly. And Zoloft, which is usually, I believe in this case, for his anxiety. He has a benign tremor and pre-diabetes. And as I said, anxiety. I believe he's on the Zoloft for that. So concerns. There's a number of concerns on this particular individual. And I'll just list them off. Age of diagnosis is a little concerning, 24. He's kind of in a pre-diabetes state, which is as we know, it's a problematic for potential CAD, and we all already know that HIV is kind of an accelerated, causes accelerated CAD. He has a neuro symptoms, and he's on Truvada, which is really, we're kind of looking for another ART med to go with that. That's kind of a PrEP med. So it's questionable whether he's on the correct type of medication. With all of these factors, it doesn't look so appetizing for us in terms of taking this particular person.
Okay, I have a couple of questions.
Sure.
Well, three. Um, do you have guidelines for COVID in the manual?
I don't think
Um,
Go ahead, Dr. J.
Oh, okay. We don't have anything in the HIV positive section about COVID, but obviously, someone might be at higher risk for COVID. So that they should definitely be taking all the appropriate precautions to prevent COVID disease on top of their HIV positive disease. One thing I should mention is you've noticed that a lot of these cases that people have been on Truvada, these are old cases that we reviewed as part of our preparation for the manual update. So a lot of people in the past were using Truvada. And so now in this case, one of the reasons we brought this case up is that's the only HIV medicine that this person is on. So we brought that up as a particular point of concern, that despite the fact that they were doing great, they're only on one medication that's usually used for PrEP. And so what did you think about their acceptability for life insurance? More questions? We're getting
Yeah,
close to the
I do
end
have
as
questions.
well. Sure.
I do have two. Concerns with depression require some reinsurance from family doctor, cause, symptoms, etc. I'm not sure if that's a question, and it says it's a question in reference to the previous file. So
Yeah, I mean, if you go back one.
You mean concerning Franklin?
Yeah, Franklin. Yeah, that is something we see as underwriters. We see that quite often where, somebody's may not be getting the treatment they should be getting. As long as we see serial medical visits where they seem to be doing well, I don't think it would be a dramatic concern. So it's just something we have to take into account. And as an underwriter, we have a snapshot in time of looking at what the person's history is, how they're doing at that moment. And if they're not having other depressive concerns, loss of work, loss of doing, things they've done in the past, angry outbursts or whatever, I don't think it would be additive as far as HIV.
No, we're really looking at more moderate to severe depression and adding a rating on for that per se, but not a synergistic situation where HIV positive depression is going to be automatically declined.
Right.
okay, there is one more question.
Sure.
We are got about 26 minutes left. Next question. You want to take it? It says, does multiple medications means that HIV is harder to control? Is this something we should be concerned with?
Doc, I don't think it means it's harder to control. I think it's like any other chronic condition, right?
Yeah, I'm sorry. Can you repeat the question, Michelle? I'm sorry.
Do multiple medications mean that it's harder to control the HIV?
I think as one of you said before, people are being tried on different medicines, and now the trend is to go to medications that are needed less frequently, like, Cabenuva or whatever. So, I think you can expect that people are going to be tried on different medicines, hopefully to find the easiest regimen for the person to adhere to and still keep their CD4 count high and the virus completely suppressed. So
And that's the overriding concern, right, Doc, is the viral load's low and the CD4 count's high. It's not really the
exactly. Now, if they have side effects from a particular medicine or whatever, so that's why they've been moved from one to another. I wouldn't necessarily say that because they're on multiple meds, maybe somebody, for whatever reason, maybe they're having to use like different, more than one medication because their plan only allows certain medications to be used, or, something along those lines. Maybe there's other factors that we don't know about why they're taking, 3 separate meds rather than a combo that has multiple, more than one variety of medication in it. So I wouldn't necessarily say that that's a negative unless there's something in the file that, gives you that impression that, they're having trouble treating this, or say the CD4 count just doesn't, come up. And despite all their best, trials of different meds. So then that would be a negative. So that's why the CD4 count and the viral load being undetectable are so key in the rating. Well, we really did get a lot of good questions. So
Definitely.
thanks to the audience for participating.
We have no more questions at this time.
What slide are we on, Grant?
Letitia. I believe.
Letitia, yeah.
Yeah,
mine.
that's the one with the 4 HIV meds. So that's kind of appropriate.
Yeah. So Letitia. Okay. So diagnosed age 34, current age 56. So she's had it for 22 years. CD4s usually in the 700s, occasionally drops down into the 5s. Viral load undetectable for many years. She's on, I can't say these medications, but I'll try. Prizita, Epsicom, Norvir, Intellence, and then she also takes some OTC supplements and on Mobic. There was a question of rheumatoid arthritis, but no real diagnosis. So she's just on the Mobic, and it's stable, not progressing. So it's just another indication. I think Doc brought this up, or Jim brought this up, about HIV meds can be very similar to trying different psych meds. You sometimes have to just go through different combinations to find the right mix for that person. So since we're all different, it's just finding whatever works for that that individual. There's a little bit possible higher rating or concern for some sort of inflammatory disease, but if it's not been diagnosed as far as RA, I don't think I would be additive as far as that. So I don't know if we have any questions.
We do have questions, and we have an answer. This is acceptable for Leticia.
Yeah.
Okay.
Yeah, this would be acceptable. Yes.
Yep, two acceptables.
Yeah, there we go.
Okay. And then a question. Can you show the medication slide, please? That's a good reference. So I can go back to that at the end, if that's okay. All right.
So I'm done with Letitia.
Rita, this is a person with HIV, diagnosed age 45, current age is 53. Viral load is undetectable, which is great since 2016. CD4s are good, but they've been kind of decreasing. They're lower now, but stable. The meds are a triplet, if I'm pronouncing that right, which was switched to Genvoya. They're also on lisinopril, which is a cholesterol med. They had, it appears they had Hep B in the past, but they're now immune, or they cleared the virus. They're compliant with meds and visits, and there's no high-risk behavior that we're aware of in the file. What's good here? The CD4s look pretty good. They're on the meds. They cleared the Hep B. Oh, sorry, the lisinopril is for hypertension, but it's controlled. And the CD4s, they're lower but stable. So this is favorable risk, I believe. And we would have a tendency to accept this person.
Yeah.
Any questions?
We have an acceptable answer.
Yeah, I think at the time when we saw the case, the person also had COVID, so we were, I think we postponed it at the time since it was a real case, but it would be acceptable once they're through the COVID protocol.
Okay, and I think this is more of a comment. It says for Frida plus 50 for combination if ALT is normal. I'm not sure if that's a question or.
Okay. Yeah.
Okay.
So a moderate or a mild rating, that's what they're saying. Yeah. So I think it's acceptable, right, Jim?
Yeah, it's a acceptable rated offer. I mean, we can't discuss specific ratings until you guys could get access to our manual, whoever is a client. Yeah.
Okay. One more question. Can you recommend a good source or site for a comprehensive list of HIV meds?
It will be on that slide I showed earlier. It's going to be better when you see it on your computer. So we'll provide that at the end.
Okay.
And just to make a point, there are medications that are used for hepatitis B that are also used for HIV. So, they may have a different name. The drug companies don't want to miss any tricks about, marketing their drugs. So they may use one name for, quote, treating hepatitis B, and then they use the different name for treating HIV. Same drug.
Sounds like a non-doctor thing, right? A marketing specialist. So. Okay, next one, please.
Next, yeah.
For Brian. Okay, so Brian is 51, diagnosed with HIV 20 years ago. Is on Viagra, Valtrex, Synthroid, Ativan, lorazepam, and levocitrazine. I think I said that correctly. So he has allergies, erectile dysfunction, he's hypothyroid, viral load range was 340 to 920 and no progression for a number of years. The viral load range, CD4 range was 461 to 589. And in big cap letters, no HIV meds. So what is going on here? So it's an interesting case. As I said, we saw this case a few years ago. And this is somebody, no suspense here, about 1 in 200 or 1 in 300 are non-viremic, long-term non-progressors, or they're called elite controllers. So there are people that clear the virus and that maintain good CD4 levels that do not have any issues, and they do not need ART medications to treat their HIV. So I wouldn't call it cured, right, Doc? But it's darn close. Yeah.
I guess I'd wonder, I don't really know. I haven't really done any research. I guess I'd worry that, if they were in a relationship with someone else, whether that other person should be taking medicine to prevent HIV just in case. But yeah, you're right. There are these rare folks that, have a favorable outcome with no HIV meds.
Yeah, and I know he's on some couple comments. He's on lorazepam, so that's a treatment for anxiety. So it is a bit of a concern, and the Ativan, but it really comes down to looking at that person over a period of time, understanding if they're well controlled on those medications for their anxiety, and if there's other issues that are present. So for the most part, this is somebody we could take, assuming we have a long snapshot, like we said, about the spreadsheet of all their viral loads and their CD4 levels. So. And no other questions. So next slide, please. Okay, as we all know, this is Magic Johnson. He was diagnosed in 1991, which in the doc and Jim and I were talking yesterday, it was kind of surprising since he was diagnosed in 91, and the original heart meds came out in 1996. So he did quite well on a mixture of medications until some antiretroviral treatment came out. So he went from a death sentence to a long surviving HIV positive individual. So it's just a reminder that HIV positive is a chronic condition, and we want to destigmatize the virus. So, with, good healthy attributes, a person with HIV positivity can live a long, healthy life, assuming there's no other comorbidities. So just some of the, to remember the favorable characteristics for risk selection. We want CD4 counts above 300 to 350. We want that undetectable viral load. We want regular follow-up testing and adherence to the outlined medication regimen. Absence of comorbid diseases such as cancer or heart disease or any other anti-inflammatory diseases, autoimmune diseases, and early diagnosis and treatment before appearance of any unusual infection. So it's probably best for a lot of people to find out that they're HIV positive, without any symptomology, or, if they find it on an insurance blood profile or they go to their doctor, they're having no issues, it's usually the best outcome. So I also just want to say, again, Optimum, we were first at insuring HIV positive individuals in 2012. The ratings that we developed back then are very, very similar to what we've revised in our manual and updated at the beginning of the year. But, a lot of these cases that we saw were examples of where we could take individuals, but, we did have a lot of postponed and declined cases. So it's, that goes without saying. We're looking, just like if somebody has cardiovascular risk factors or cancerous process, we're looking for, the best clients that are going to have good long-term outcomes. Jim or Dr. J, you have anything else to add?
Yeah, I would say that of the cases I've seen since I've been at Optimum Re with HIV positive applicants, in many of the cases, the HIV disease has been well controlled, and it's usually something else that I have to be more concerned about. So, it has become one of the factors, but not the only factor that, we have to take a look at. So I've been impressed with how well the medications are working. And, many people can have a very good outcome with effective treatment.
Okay, we have one question back on the slide for Brian. Try and move backwards. Let's see. Oh, there he is. The question says, no antiviral treatment. Prior to offering, I would prefer to see the history of CD4 count and viral load for at least the past 5 years.
Yep.
Yeah, definitely. That's a good point.
Yeah, I think you'd want to be sure. We're kind of using this as just an example of, hey, some people can even make it without medication. But you're right. You want to, on this particular kind of a case, you'd want to have every possible test that they've had done to make sure that the trend is either stable or improving and not getting worse.
Okay. And we have another question. I think this may have been addressed, but does Optimum have any guidelines for clients who are not HIV positive but do take preventative medication against it?
Yeah, we do. It's in our manual under the PrEP and PEP section that Dr. J talked about earlier. Dr. J, you want to talk any more about that?
Yeah, so we kept them separate, so we didn't put it in this section. Some companies that we've talked with prefer to lump them together. We wanted to keep it clear for the underwriters that we're considering this as a different thing from PrEP. But yeah, it's always good to in your manual have some indication of what the underwriters should do with PrEP and PEP. We kept it separate, and as I kind of described before, we don't take any adverse action just for somebody using PrEP or PEP unless there's some other reason that there's a objective evidence of disease, then we would act on that. So it's kind of like there's a lot of other factors where you really don't want to put information in your notes or take adverse action unless you have something objective to rate.
So I think, Jim, do you have anything else, or I was just going to?
Not really. I mean, a lot of these things are recent additions. We kind of went through, PEP and PrEP and put them in the manual. We hadn't had HIV positive in the manual previously, but we've recently put it in. So, these are a lot of these are kind of additions to our manual, we were looking at those issues kind of separately and obviously insuring people. But we basically started in Canada insuring HIV positive individuals. We hadn't done that in the state. In Canada, we'd done it in the States for many, many years, as Dave said.
Yeah, we know some companies are limiting, taking HIV positive risks to the state of California with their new law, but we feel it's important to open it up to North America, the U.S. and Canada. We feel very right on with our ratings for these individuals. We know not only our internal underwriters, but our client company underwriters are going to do the right thing when they're assessing risk. So we think if you follow the guidelines as we developed, you should be spot on as far as being able to insure HIV positive individuals. And with the new developments in California, there's going to be other states to follow. So, it's definitely going to be throughout the U.S. at some point in the near future.
Okay. We have a question regarding getting APS. Do you get APS from the DP and from the specialist, the infectious disease specialist? Can you offer guidance in that area?
Well, you definitely want to get the HIV specialist APS. Hopefully there's enough information in there to guide you. As I said, a lot of times when I would look at a case of an HIV positive applicant, the HIV disease was well controlled and it was something else that they got declined for. For instance, somebody was, their HIV disease was controlled and they were smoking meth, which, you wonder, really? But anyway, so obviously we don't accept people that are smoking meth. So, those are the kind of things you run into.
Okay. And we have two other questions, but I can answer these. Yes, we will be sharing a copy of the slides, and the recording of the webinar will be made available on our website.
And I hope that everyone, when you have a question, I know this is relatively new for most people, so you may want to. We're happy to hold your hand as you wade in and get a feel for what's going on with these kind of clients. But we have the expertise here. We're more than happy to work with you in any way we can to help out. So we're at your service.
Definitely. I think there's a couple, or just one more slide. This is, and we will post this on our website. So these are some resources you can look at when you get time. But that's, I think the next slide is just any questions. If there's any other questions, we'd be glad to answer them. And if you don't want to ask a question now, feel free to reach out to us, me, Anastasia Jagerman, the chief underwriter, Jill Thompson, our team in the US, or Jim's team up in Canada. So.
Got it. Excellent discussion.
Great.
So thank you to our panelists. It was an excellent discussion. I work in claims, and this is all new to me too, and it's good information to know. Any other questions before we go? Okay. So for the person that was asking for the medication slide, again, we will share these with you, and the recording will be on our website. Any other questions?
You want to put that med slide up real quick so they can copy that
Sure.
down if they're so inclined?
Let's see.
I think it's slide 12.
12. Okay.
Yeah.
Thank you.
I know down at the bottom, I don't know if you can see it, but it's basically, if you go to poz.com, it's going to link you to that.
Yeah, I actually copied it off images. It was very easy on Google.
Yeah, and sorry that it's not a great slide, but it is what it is. So.
Any other questions? Okay, well, we'll wrap it up. Again, thank you to all of our attendees and participants. Thank you for the questions. Made for a very good discussion. And of course, thank you to our 3 expert panelists. for all of your expert information. Please remember, as Dr. Joannides said, we are available to you to walk you through whatever case you may have. And we appreciate all that you do. And I
Thanks,
guess that's
Michelle.
it.
Appreciate
Thank you,
it.
Michelle.
Thank you,
Thank
Michelle.
Thanks,
you.
Jim. Thanks, Dr. Jim.
Yep.
Take care, everyone.
Bye.
Okay.
Bye.